This third category of drugs include the Biguanides, and the classic example is metformin. If it's one drug class that you have to know, it's metformin. Okay, metformin is the statin of diabetic drugs. It's the staple of pretty much all type 2 diabetes therapy, and it has profound uses in managing hyperglycemia. Okay, so this is the one drug you definitely should know. From a mechanistic standpoint, it goes after AMPK kinase, and by doing so, it reduces liver glucose production, and it does it quite well. By the way, it also reduces hepatic gluconeogenesis, and it also increases sensitivity. So patients who are also managed with insulin, it makes their insulin actually more potent. Okay, so over time, you can see these patients using a little bit less insulin once they go on metformin. Okay, so the target population is really all patients that have type 2 diabetes and that don't have any contraindication to metformin. We'll talk about some of those contraindications later, but they're very few. And so, the primary glucose target is looking at fasting. And so these are all the sites of activity where metformin has an effect. You can have it reduce glucose uptake within the muscle. You can see an enhanced gluconeogenesis at the liver. And you can see reduced glucose uptake within the adipose of the fat tissue. Okay, and there's other non-canonical or non-standard effects of metformin outside of diabetes. Looking at it as an adjuvant to chemotherapy, its ability to alter the Warburg effect. So this is really a powerful drug, and you'll probably see a lot more of it clinically over the next couple, 4 to 5 years. It has great efficacy. It'll reduce plasma fasting glucose concentrations to anywhere from 60 to 80 milligrams per deciliter. And it's really the most potent orally administered drug out there that can reduce A1C. Okay, it'll reduce A1C from anywhere from 1.5% to 2%, which is really strong. Outside of hypoglycemia, which is more commonly encountered with other drugs, we don't really see that with metformin. The most common adverse effect with metformin, and this is why it's a little bit unique, is GI discomfort. So patients complain of gas, abdominal bloating, diarrhea, and so that's really the most troublesome. And I wouldn't even know if I would call it an adverse effect. It's more of a side effect, but it's annoying with this drug. There is a rare adverse effect where lactic acidosis can occur. There was another generation of Biguanides that was produced. There was another Formin. I forget the beginning part of it. Let me see if I can find it right here on my computer really quick. Fenformin, yeah, Fenformin was the older version of metformin, and it was actually really potent in terms of A1C reduction, but it actually produced lactic acidosis in almost all patients, and so that one got scrapped, and then metformin got further developed. You can also see metformin being suggested for patients that have underlying cardiovascular disease and are obese. And so this is really a great drug. And the obesity component and the cardiovascular component kind of gets to the Warburg effect. And I'm not going to talk about it here because I don't want to go into it because it's out of the scope of this particular lecture. But if you look it up, it'll be an interesting topic later on when we talk about oncology. There are some minor contraindications to metformin, and that is due to basic renal clearance. And so you can look at serum creatinine levels in both men and women, and if it's above a certain point listed here, then it's safe to give this drug. There is the possibility of exacerbating acidosis, and so of course if the patient already has metabolic acidosis, you wouldn't want to give metformin. There is some congestion problems in terms of CHF, so you wouldn't want to give metformin. And then you also don't want to give metformin within 2 days of using IV contrast for any kind of activity. So there's an interaction there. But other than that, it's relatively a safe drug, well tolerated. There's different formulations. There's an immediate release and an extended release, and it really just kind of gets to how long the drug has an effect. And so the immediate release obviously would have an immediate response or immediate effect. The extended release can kind of get you through the day, so you can at least get metformin maybe twice a day. The 80 is twice a day. Typically, these doses are started low, and then we kind of increase the dose as the patient requires it. From a advantages and disadvantages, you almost never see hypoglycemia or weight gain with metformin, and this is why it's kind of the preferred type 2 diabetic oral agent. And in fact, there's clinical trials that show that in the patients that have underlying cardiovascular disease and or obesity, they actually do quite well on metformin. We've got extensive experience with this, and it's relatively cheap. And the main disadvantages really come down to the GI upset, the possibility of multiple daily doses, and then a slow titration phase in terms of getting patients where they need to be to maintain serum glucose levels. Okay? But those adverse effects are usually transient. If the patient takes it with meals and you titrate the dose slowly, typically we don't have problems with metformin. It's really well tolerated, and I said it's kind of like the statin of diabetic care. And so many diabetics are already on statins too, and metformin is a really nice adjuvant to that therapy as well. So metformin, great drug. Your patients will most likely be on it. You'll be prescribing it a lot.